Thank you very much. I'm delighted to be here. It's a great honor to know the Sanis company. I must confess, I did not know about them until a few months ago. And of course, you probably didn't either. They're new, very innovative, very futuristic, and I must say, very venturesome, and they've got what it takes these days to do great things, and I'm happy to present here. Some of you do know that over the years, I've probably been the person who has advocated or pushed, if you will, to bring hormone testing and treatment into pain care. It's been a long time in coming. The research goes back many, many years. There are many, many people who have done a lot of things in this field, and I'll give you a little overview of it tonight. And above all, for those of you who are physicians or who are practitioners, my purpose, of course, is to encourage you to embrace this new component of pain care. A couple of other things. I said it's an adjunct, it's a new thing, it's a component. It's not a replacement of what we're doing today. We're not going to replace epidural injections, opioids, neuropathic agents, physical therapy, or anything else. This is an adjunct, something that we're bringing to it. That's number one. Number two, I like to warn everybody right out front that the use of hormone testing and treatment in pain care is something that you don't have to be an endocrinologist to do. Now, my background, incidentally, is internal medicine, endocrinology, and I trained down at UTMB many, many years ago. That's where I did my medicine residency. The procedures and the knowledge is such that anybody can learn this. And I tell people this to get over the fright of it, because it's like anything else in medicine. If you haven't been trained in it, you don't know about it, you feel you can't do it, you got to refer to someone else. But let me just assure you that what we're doing in pain care and hormones can be done by any good nurse practitioner, PA. And in fact, among those of you who are physicians here today, I would suggest to you that within 2, 3, 5 years, you'll be supervising PAs, NPs, PharmDs who will be doing the hormone work, not yourself. So you'll become a supervisor of administering these things, and I'm quite sure of that. So, now, why do I say confidently that hormones testing and treatment is here to stay? And it's right here on this slide. You don't have to be a whiz kid to figure out that when hormones do all of these things in the body, it's here to stay. We're going to use hormones. It's as simple as that. Now, most of you know most of this, but I'll bet you there's a few things here you don't know, and things that have come out of research literally in the last decade. And that is, hormones have certain effects in the central nervous system that are not known to the general practice of medicine. And I always want to summarize a couple of those. For example, people don't have any idea and don't know that the mu-opioid receptor is totally regulated by hormones. If you don't have enough testosterone or pregnenolone or cortisol in that serum, your morphine isn't going to work. Even your intrathecal pump's not going to work very good because those receptors are regulated by hormones. Nerve conduction in the central nervous system. And here's two words that I want you to know: neuroprotection and neurogenesis. They're the new kids on the block, and I'm going to talk about neurohormones in a couple of minutes because their function is to protect hormonally the neurons in the central nervous system, including the spinal cord and the cauda equina, as well as neurogenesis, which simply means regrowth or growth of nerves. And also, hormones maintain the blood-brain barrier. We never talk about that very much, but when you've got a leaky blood-brain barrier, all your neuropathic agents and your antidepressants aren't going to work very good. So all our pharmacology, that we use is fundamentally based on having good hormone levels. And so people all the time say, well, if I give them hormones, are they going to stop their opioids? Are they going to do this or that? Maybe not. That's not the point. The point is to give them a physiologic system that works. And it's all hormonally controlled. Now, we know that there are 7 or 8 hormones in the body that are very close, they're very important to pain control. And I'm going to list the ones we know about. There may be some others that are important to pain management, but we know these are. Estradiol, thyroid, human chorionic gonadotrophin, oxytocin, cortisol, pregnenolone, DHEA, progesterone, and testosterone. We know that these hormones are well documented to have various effects on pain management and pain control. There may be some other hormones out there that we don't know about, but these are the ones that we know about. Neurohormone. A neurohormone, according to Dorland's dictionary, is a hormone secreted by a specialized neuron into the bloodstream, the cerebral spinal fluid, or the intracellular spaces of the nervous system. And Dr. Hormone says neurohormones are essential for treatment of centralized pain states. Ladies and gentlemen, it is my personal belief that the most important scientific discovery of the last decade relative to pain management is that the central nervous system makes these hormones. It not only makes these hormones, it keeps them within the central nervous system and uses them. In some cases, we don't even quite know where they are made. And in some instances, we don't quite know, what they do. But we do know they're important. Pain management's future is right here. It is impressive to take a look, for example, at studies in rats in which spinal cords have been severed, and to see those rats given pregnenolone or progesterone or chorionic gonadotrophin, and literally see a rat that's walking around the cage with his hind legs dragging. 6 weeks later, that spinal cord's put back together because they were taking chorionic gonadotrophin or pregnenolone. Those studies aren't well known. And in fact, we're trying to do a little review article on that. It'll appear, I think, in 2 months from now in pain management. The bottom line is, these things, we don't know a lot about how to give them yet. We don't know a lot about dosages, but we sure know you got to have them to do some things. I'll make another bold statement in my own practice. And let me tell you a little bit about my own practice. Clear back in 1975, we started in Los Angeles a special clinic. And in those days, the DEA and the Department of Justice wanted me to get in doing it because I was the public health officer, and we were the only ones that prescribed narcotics in those days. And so we started a clinic clear back in 1975 to take patients who were on opioids and who were failing standard treatments, and we've been running that clinic ever since. So we literally have some patients who've been on opioids 30 years. So we've been taking these patients for 40 years who have failed everything else but have to take opioid drugs. Let me just say very frankly, until we started using these neurohormones, I never saw anything that really reduced opioid dosages in the severe cases. But we use half the opioids today that we did 4 and 5 years ago. And mainly because we're doing all kinds of studies on how to use these hormones. We've got probably right now in my own clinic 50-some people on chorionic gonadotrophin and oxytocin, plus a variety on the other ones. We're in the elementary stages, but I do want to tell you how important neurohormones are in the future. And neurohormone administration is just frankly essential to control and mitigate some centralized pain states. I've gotten kind of spoiled. I frankly wouldn't want to be out here today treating RSD or CRPS or post-viral syndromes or arachnoiditis without neurohormones. I mean, we've gone about as far as we can go with our standard treatments, our epidurals, our intrathecal pumps, our stimulators, our opioids, our neuropathic agents. We've gone about as far as we can go. And we've got to have something new, in fact, just to make these old modalities work better. Neurohormones, again, at this point, in my own unit, they're considered essential. And again, I have a research unit, so again, I'm talking a little futuristic, so I don't expect anybody to try to duplicate what I'm doing quite yet, except I do think it's coming. And frankly, everything I'm talking about here is easy to do. Easy to do. Before I go on, I want to make one other statement. Anybody in here lately prescribed Neurontin? Sure. Anybody here lately prescribed a Percocet? Anybody here lately prescribed a Zymbalta? Every one of those agents are far more dangerous than any of these hormones. Have far more complications, far more complex. If you can prescribe Zymbalta, you can sure prescribe those agents. It's just that you haven't done it, you're not familiar with it, but we use things every day in pain management that are far more risky, far more dangerous, and have far more complications than these hormones do. It's just that it's new, it's different, and sounds scary, but it's not. I want to talk about the basic effect of pain on the endocrine system. Now, what I'm about to tell you, I'm going to cover in about 45 seconds. But the understanding of this took 45 years. This was not simple to understand. And the studies go back into the 1950s. The British, after World War II, actually did a lot of studies on British soldiers on hormones. They were really the first to measure cortisone in urine and what have you in people who had intractable pain. The Americans started doing some studies in the late 50s, but, and I'll show in a minute, our first real study was done in 1964 by Dr. Schenken, and I'll mention his studies in just a moment. But here's the point I'm trying to make. Pain has a biphasic effect on hormones of the body. In step one, phase one, uncontrolled pain causes a signal in the hypothalamus to activate releasing hormones, which activates the pituitary gland, which secretes a certain number of other hormones, and serum hormone levels rise. Now, if that pain is not controlled after a while, something wears out. Either a releasing hormone in the hypothalamus, or a secretory hormone in the pituitary, or a hormone in the adrenal gland or the gonads depletes or suppresses or exhausts or fatigues, call it what you want, and therefore serum hormone levels drop. And so when you start doing testing, you have to understand this biphasic effect of pain on the endocrine system. In fact, you can have, these guys are measuring, they said 14 hormones. Some of those hormones might be up at the same time, some might be down. And so you've got to kind of figure out what's being stimulated and what's not being stimulated. But it's a biphasic situation. Now, when you get into phase two, to where serum hormone levels drop, in my opinion, that's a good time to replace those hormones, or at least do what we call sub-replacement, low-dose substitution of bioidentical hormones until you bring the levels up. Is what is the easy thing to do and should be done, in my opinion, these days. But remember, it's a biphasic system. Here's the first seminal hormone study done in the United States. It goes back to 1964, when Dr. Schenken was able to take something called the old Porter-Silver chromogen test. That was invented around 1957. The most famous person to ever probably be tested with that was John F. Kennedy. And anyway, Porter-Silver tests were available in 1964. And Dr. Schenken was a neurologist in Philadelphia, and he took hospitalized pain patients and found that those people had 85% of hospitalized pain patients had elevated cortisol levels compared to 15% of non-pain patients. And he published that in the Journal of Neurology in 1964. That is our seminal study, and since that time, there's a few dozen articles in the literature, including some of my own, that have to do with this biphasic system of hormones go up with pain that's uncontrolled, and after a while the hormones go down. A little bit of history. In 1855, Dr. Thomas Addison published his 11 cases of what's now known as Addison's disease. And he published it in a beautiful manual called Diseases of the Suprarenal Gland. And what's not appreciated, he had 11 cases. 2 of those cases looked like they died of adrenal failure due to intractable pain. The other 9 cases either had cancer or tuberculosis. But 2 of the patients just seemed to die of pain problems. One had a neuropathy of the face, and one looked like probably had some infection of the spine, probably arachnoiditis. But nevertheless, this shows you the dramatic second phase, if you will. The too much pain caused death. He actually had an interesting thing. He actually hired an artist to go into the morgue and paint his 11 victims, color his 11 victims. And so these are the photographs, not photographs, but the lithographs that the artist wrote of them. And here's one of his patients who seemingly died of nothing but pain. And he's got dark skin, he's got the yellowish skin. His name was Harry Patton. Here's the other patient of his that died, seemingly of only pain itself. He also talked a lot about the brown spots, which a lot of people who've been around Addison's disease have seen, the dark brown spots, but he also published pictures. And if you go back here, these are almost freckles, if you will, here on the omentum. And it was interesting is that at autopsy, he found these brown speckles on both the skin as well as in the intestinal organs. And he published all this in 1855. And you know what? Nobody's done that since. Nobody's bothered to photograph these things. Nobody's bothered to draw them. See, you've got to go back to 1855 to get the facts. Anyway, here's a patient of mine. She was sent to me from Minnesota. She'd seen everybody there, you know, all the big people, Mayos and everybody else. Nobody knew what to do with her, and she was clearly dying. Had some kind of a terrible back problem, fatigued, losing weight. She comes into the clinic, and I take one look at her and see all those brown spots, and she's a little yellowish. Well, I sure know what to do. She's got a cortisol under 1. So she's dying of adrenal failure. And she's not on opioids, she's just dying of pain. Another one, a very wealthy lady from San Marino comes in and has these brown spots on her back. And again, fatigued, failing all the standard pain treatments. And again, we take her cortisol levels, they're under 1. And so I don't know how many of these people are out there in society. I hope not many. But the point to be made is that you can actually, pain itself can lower hormone levels down to where it can be a life-threatening situation. You don't see it very commonly, and you may never see it in your career, but we have seen people get levels of testosterone and DHEA and pregnenolone down to trace levels, and you do wonder why they're still walking around. And this is not people on opioids. These are just people with severe pain that's not well controlled. Here's the most famous person who was a pain patient and on hormones. Now, I wrote this story about John F. Kennedy. I did not know John F. Kennedy, but I did have some familiarity with his doctor, Dr. Travell, Janet Travell, who was really the father of modern pain management. Dr. Travell got John F. Kennedy as a patient in 1955 after he had had several back surgeries. He was despondent, losing weight, couldn't function, couldn't walk. He was in a wheelchair. She took him, hospitalized him, put him immediately on methadone, stabilized him, sort of saved his life, and she took care of him up until the time of his assassination. He had an interesting, very fascinating case. It has a lot of misinformation. It turns out that the Kennedy family in about 2003 allowed a physician and a reporter from the Atlanta Courier, I believe, to go in to see the medical records and take whatever pictures they need. And then a Navy physician who was an endocrinologist actually analyzed the records, and I was able to obtain these things and write this story. A fascinating story. He actually had a genetic disease. In fact, his whole family did. Something called Smith syndrome. It's an autoimmune polyglandular syndrome in which you may have a bad pituitary, a bad thyroid, a bad adrenal, bad gonad, bad pancreas. You'll have a series of endocrine organs that may go bad. And he had his own that went bad. His adrenal gland did, and also his thyroid. His pain problem was threefold. severe spine degeneration. It was aggravated by an injury during World War II. Had severe osteoporosis even before he went into the military. And he had several failed surgeries. Might surprise you, he was put on methadone and opioids in 1955 and maintained on those drugs up until he was assassinated in Dallas. And I guarantee you he exceeded the CDC guidelines. Let me just stop for a second. You know, we've seen a lot of this stuff in the media, and let me just make it, I don't want to dwell on it, except throw in my 2 cents about something. I think it's terrible in this country when you see federal agencies and the media. I mean, we physicians, we're used to being bad-mouthed. Okay, we're used to it. But this time, they've taken on an awful lot of nice patients. There's about 10 or 11 million people who take opioids regularly in this country. And many of those people are physicians, police chiefs, lawyers, executives. And so there's an awful lot of good people who take opioid drugs. But to sit around and come up with this obscure thing called a substance abuse disorder, define that one for me. They've got that down there to where if you're a grandma who's 92 years old and taking 3 Vicodin, you're a substance abuse disorder case. It's a little frightening to see some of the things that they've talked about. And like I say, why don't they bring up John F. Kennedy? Now, Howard Hughes took about 200 milligrams of morphine equivalents a day after his plane crash in 1946, and he lived 30 years. Built Las Vegas, built Hollywood, built planes, did all other kinds of things. So this idea that people are all substance abuse disorder people and don't function and opioids are bad, that's just not true. Just not true. And it's up to all of us to let them know that disease happens, suffering happens, misery happens, and it's our job to relieve that regardless of what it takes. So I wanted to make that point. That is, it is shameful that we're telling people who are terribly ill and doing terribly well on opioid drugs that they're bad people, Okay. Now, nobody likes opioid drugs. I don't know where that came from. Anybody here like prescribing opioids? I hate it when I got to bring out that pad and write that. Nobody likes doing this. We do it because it's our only alternative. So, and Kennedy is a good example. Now, Kennedy also took 4 hormones. Okay? Took these 4 hormones. And the most fascinating is human chorionic gonadotropin. He actually took injections of that back in those days. And he made the comment to some of his doctors and his aides who didn't like him taking it. Back in those days, in order to get human chorionic gonadotropin, you had to extract it from pregnant mares or pregnant horses' urine. And they didn't like him taking the HCG shots because he had to take that from somebody other than the White House physicians. And guess what he told them? He says, I don't care if it is horse piss, it works. Need I say more? Need I say more? In other words, these things work. We know a lot of things, but the criticism we get these days for various reasons is really, really kind of sad. Now let's talk about opioids. Nobody likes opioids. They're a last resort treatment. And when people have to use them today, you have to be very clear about this. They're going to suppress the endocrine system. Now, if you're going to use a long-acting opioid or intrathecal opioids, you're looking at 95% of those people are going to suppress opioids. If you're even using short-acting opioids, in some cases even a tramadol or a codeine, you may suppress opioids. So, unfortunately, when we have to go to opioids, we're looking at hormone insufficiencies. But now, let me tell you something else. Our neuropathic agents do the same thing. Our antidepressants do the same thing. A lot of our anti-inflammatories do the same thing. Maybe not as bad as opioids, but guess what? Most of our bad pain patients out there, they're on neuropathic agents, antidepressants, anti-inflammatories, muscle relaxants, sleep aids, ketamine, and opioids, and you bet those hormones are going to be suppressed. So we have the burden today of testing these people and trying to replace the hormones that are caused by the opioids. Now, interestingly enough, the opioids preferentially suppress the gonadotrophic releasing hormones in the hypothalamus, sometimes the cortisone releasing hormone, but it preferentially will suppress testosterone and estradiol. Now, we're not really quite sure why, but that is the ones that they preferentially suppress. However, opioids, neuropathic agents, and antidepressants will also suppress cortisol, DHEA, pregnenolone, thyroid. All those can be suppressed. And sometimes one is suppressed but not the others, and we don't quite understand it. And that's another reason why we test, so we can figure out which ones are suppressed. Long-acting opioids or intrathecal opioids, it's like night follows day. And so anytime you've got to use that fentanyl patch or the intrathecal pump, methadone, OxyContin, you just have to assume you're going to get endocrine suppression. This is the major complication of opioid drugs, in my opinion. That's the one that's universal, and it's just part of the deal. If we have to use opioids, we're going to have to replace hormones. Who should be screened for hormone abnormalities? I've given you some list here and don't want to dwell on it too much, but again, I've already talked about one. Anybody who needs daily opioids really should have their hormones tested. Anybody who complains about their current treatment regimen is not working. All of us see these people, they've been in our practice for a while, and all of a sudden they come in one day and they say, gee, this isn't working anymore. It's a good candidate. Those people who have centralized pain, including traumatic brain injury, they're going to have to be tested. Some of these brain injury cases actually do develop true hypopituitarism. Now, let me stop right here for a second. Almost all the pain patients you're going to work with don't need to see an endocrinologist for one reason. The gland is still normal. It's not a diseased adrenal gland or diseased ovary or diseased pituitary. It's a normal gland that's been suppressed by the pain or by the opioids or a combination. And all we need in those cases are a little maybe more pain control in some cases or some low-dose replacement. In other words, an endocrinologist is not interested in seeing your case that's got a normal adrenal gland. Now, if that adrenal gland is gone due to autoimmune disease, yeah, he's going to be interested. But that's not the usual thing in pain management. Now, those patients who complain about hyperalgesia, fatigue, weakness, and some of these other things, they ought to be tested too. You know, I hardly ever see hyperalgesia anymore. Why? I test them. When somebody that I think is developing hyperalgesia, the number one hormone I find depleted is pregnenolone. I replaced the pregnenolone. Hyperalgesia is gone. Or it may be testosterone or DHEA, one of the other hormones. Hormone administration, there's an increasing number of reports, some controlled, some not, that start showing that patients who do take hormone administration get these kind of effects. Fundamentally, they get a better quality of life, they function better. And I don't think people want to go out and give the hormones thinking they're going to either reduce a whole lot of opioids or they're going to get better pain relief. You are going to get something positive, but it may be any number of these things, or it may just be one or two. But I can tell you this, patients sure do respond. And they certainly comply better and like it better. And you get other things that seem to go along with hormone administration, less depression, less hyperalgesia, less hopelessness. And effects on pain. Incidentally, in pain research, everybody is too hung up, in my opinion, on pain scores. When you're going to do research or evaluate a patient just clinically, in my opinion, you're a whole lot better trying to look at some of these things rather than just looking at your pain score. Are you getting some pain-free hours, fewer flares, longer intervals between flares, some other kind of measurement just besides the pain score? And to close out, I want to come back for just a moment and close with this slide, and that is, in my own work, I like to take the worst case I can find. I've been at this a long time, and I personally like to get the cases that other doctors are having trouble with and nobody seems to want to take them. I'll take them. I'm a little filled right now, and I got a waiting list, but I sure will take them if I can. And because these kind of difficult syndromes are out here today, arachnoiditis, post-viral syndromes, CRPS. These are terrible conditions. Somebody has to take them. I like taking them, but I will tell you this, I would not want to manage these cases without the ability to do hormone testing and treatment. This completes my, I'm not finished, hold that applause. I tried to cover a lot of stuff in a short time. I'm going to stick around afterward. The best hormone I know is still GABA-aminobutyric acid derivatives that they serve at the bar. Also, for those of you who are practitioners, if you give me a business card, I've got a little hormone bulletin I send out once a month just to keep people updated. They're handed out here an article that's going to come out in Practical Pain Management in about a week. And we gave you sort of a pre-publication update copy. And my last thing is this. Don't feel you've got to know what I know. Don't feel you've got to be able to stand up here and give this lecture. Don't feel you've got to do anything very fast. Take it slow. Do one thing at a time. Do a little testing, maybe replace one hormone, do this. This is going to be with us from now on. There is no reason to get in a hurry to learn this or implement it. Don't get discouraged with it. Just take it progressively. Put your toe in the water, and you'll get there. It's like anything else in medicine. Once you finally get the hang of it, you'll look back and say, hey, it's not hard at all. And so, but just don't try to do too much too fast. I know I've met some of you before. There's some esteemed people here in the audience. I understand we have a young lady here today who's just got a great appointment somewhere, like the White House or somewhere like that. I don't know. Anyway, and I know the company's doing some great things. It's an honor for me to be here, and I'll look forward to getting to know all of you better. You've been a kind audience. I wish you the best of luck.